One, this is sealants. Okay, you guys can see the PowerPoint? Hello?
Yeah, I can see it.
Okay. Alrighty, so we're going to talk about dental sealants today and the indications, contraindications, why we put sealants on. It helps to prevent caries development. So dental sealants represent one of the greatest advances of modern dentistry. Unfortunately, too many children do not receive the protective benefits of dental sealants. The purpose is to prevent dental caries in the pits and fissures, and they cover the tooth surface and prevent bacteria and food particles from settling into the pits and fissures of the tooth. How they work. Bacteria accumulate in the narrow pits and fissures. Even a single toothbrush bristle is too large to enter and clean pits and fissures. And the sealants, they act as a barrier. So here is a fissure. So this is a side view, but on the top, you see all these little tiny cracks and crevices on the top of the tooth. Those are called your pits and fissures. On your side view, what you don't see is that they run deep. And when we usually brush, the tooth bristles only get up here. The tooth bristles do not fall into those cracks. So what happens is debris, food accumulates in these pits and fissures, and it's impossible to get it clean unless we cover them with a sealant. Now, a properly placed sealant should look like this. So here's all the pits and fissures, and the sealants are covering. So now when the patient brushes, they can clean the surfaces. It's nice and smooth. And again, that's a very good sealant placement there. Now, dental caries and sealants. During sealant placement, some bacteria will be trapped beneath the sealants, and some teeth with very small initial carious lesions may be inadvertently sealed. So if a tooth is just starting to get a cavity and it's not deep, the doctor will say fill it with a sealant. The deep ones cannot be filled with a sealant, okay? Now, numerous studies have shown that neither of these occurrences will increase the chance of caries development, or the caries will grow beneath the sealant. Several studies show that bacteria in small existing carious lesions that have been sealed decrease dramatically with time. So usually the pits and fissure sealants are roughly put on children. Insurances only cover them to a certain age. Also, usually it's about 16, okay? And then after that, they just have to be careful. Now, if they're a little bit older and they want sealants, of course, we can place them. But if they're doing a really good job keeping their teeth clean and they don't have any cavities, then it's not necessary. So again, pit and fissure sealants are especially useful for the selected patients through the caries active period from 6 to 15 years. You really put them on for teeth with deep pits and fissures, and preferably in recently erupted teeth. So usually over 4 years of age. Sealant should be used as a part of a preventative program that includes the use of fluorides, dietary considerations, plaque control, and regular dental exams. Um, Again, they're mostly used on children, some adults, but not many. Now, when we don't use sealants, so contraindications, when they have lack of pits and fissures, when they have occlusal decay, interproximal decay, insufficient eruption of a tooth, soon to be lost primary teeth, and poor patient cooperation in the dental chair. Because the only way a sealant is going to stay on the tooth is proper isolation. If the tooth is full of saliva and the patient doesn't cooperate, then we really can't put a sealant on. Now, there are types of sealant materials. There's a wide variety, and you should have a thorough understanding of the characteristics of the various sealant products that are available. So here is universal liquid and catalyst vials. So some of the etch comes in liquid. The etch we've been using comes in more like a gel. Okay, it stays on the tooth. You can use either or, whatever you the office has. Now, the method of polymerization means setting or cure. So there's two types of comparable in bond strength and rate of retention. We have the self-cure materials. They come in two parts, a base and catalyst. We can mix these pastes together and they quickly polymerize, which means harden. Then you have the light cure sealants that do not require mixing. Once you apply them to the tooth, you use the curing light and it activates the setting. Now, most offices use the light cure, okay? Now, sealants also come in colors. Sealants may be clear, tinted, or opaque. So usually the ones that are used in the office are the opaque. For little kids, sometimes they use the color ones, because those teeth are going to fall anyway. But for the permanent teeth, we usually use white, so that way you don't see these colors on their pits and fissures. Usually they could be pink or blue or even orange or yellow. I've even seen green. Now, tinted or opaque sealants are more popular because they are easier to see than clear sealants. During application, sealants for sealant retention on subsequent office visits. Some brands have a tint that is visible during the application but turns clear after polymerization. So again, you may use a sealant that has a color, and then once you cure them, it goes to white. I don't like the clear because the clear is clear, and then you can't see if it's a sealant on there or not. It's really hard to tell. Now, there's some fillers. Sealant materials are available as filled or unfilled resins. The purpose of filler material in the sealant is to make it wear resistant. Filled and unfilled sealants penetrate the fissures equally well, and there's no difference in micro leakage. Some dentists believe that a filled sealant is better because of a lower wear rate on occlusal surfaces. Other dentists believe that because sealants flow deep into the pits and fissures to form a barrier, it ensures that the occlusal wear is insignificant. Now, you have some working time. Self-cure sealants polymerize to final set within approximately 2 minutes from the start of mixing the two components. And light cured material has the following advantages. Again, it does not require mixing. It allows the operator to place and cure the material when the operator is ready. And that's one of the reasons why that one is more the one that's more thoroughly used, widely used in the dental office, because you can place it, you can remove if you put too much, and then you can cure it. So you have a little bit of working time. The other one, once you pass the working time, you're done. If you didn't do it right, you got to start all over again, and it's a real pain. Now, any moisture on the tooth can result in failure of the sealant to adhere. Moisture could come from saliva, from an air water syringe that leaks water into the air, or even from the patient's breath. If moisture contamination occurs, the sealant could be lost immediately or partially lost at a later date. Also, leakage could occur around the partially retained sealant, resulting in decay beneath the sealant. So usually the maxillary mandibular second molars are the teeth that are most frequently, they lose the sealants, probably because they're the most difficult teeth for which to maintain isolation. Okay, so if that happens, we have to replace them. So here is a setup for placement of dental sealants. Now, curing lights come in many different ways. They come like this. They come like the ones we have in our lab, but that's a curing light. This here, either it has the shield on the curing light or you use a paddle to cover the light from hitting your eyes. The goggles are for the patients. Now, sometimes the goggles also can be in orange. If they have the clear goggles, when you turn on the curing light, you ask them to close their eyes. Here, you should all know what a basic looks like. Mouth mirror, explorer, and cotton pliers. The articulating holder and the paper. The etch. Now, so here is the blue etch we were using. Again, there's different type of etch. It's liquid. If you use the liquid, you're going to need a dapping dish and a brush to pick up the liquid. This is the sealant. Now, before you even place a sealant, the tooth must be clean, and you clean it with pumice. You must remember that, pumice. Pumice, you mix it into a paste, not too dry, not too wet, just right. And you use either a cup or a brush to clean the pits and fissures. Usually the brush is much better to clean the pits and fissures. Of course, you need floss, you need your HVE. I don't see the saliva ejector, you need your saliva ejector. Tons of cotton rolls. I don't see gauze. Gauze is helpful too. Okay, so this would be your setup more or less with the things that I told you. Also, make sure that you have that are missing on here. And then important, isolate and dry. Now here's what the pumice looks like. Okay, it looks sort of grayish white color. When you etch the tooth, okay, when you etch the tooth, you usually leave the etch anywhere from 15 seconds. It could be up to 60. Again, it all depends on which brand you're using. The one that we use is usually 15 to 30 seconds. Now, you really want to make sure that when you etch, you leave the etch on for that amount of time, because when you do, okay, when you put the etch on, after you do the etch, if you did it correctly, the tooth is going to lose its shine. And when it loses shine, you did the etch correctly. It'll lose its shine. It's going to look dull, chalky, and white. And then you can place the sealant in the pits and fissures. Okay, so all these pits and fissures that you see here, you will place the sealant, and then you will cure it, and then you will evaluate it. Okay, so once you cure it, you check with the Explorer, make sure it is hard, make sure that the sealant is nicely in there. When you put the Explorer on it, it should glide like ice. Okay, it should feel like ice. If you have any catches, if you have any bubbles, you have to redo that sealant again. You want to make sure it's nice and smooth. And then, so etching, you got to take care that the etching does not contact adjacent teeth or soft tissue. Is only meant for that tooth. Bite interference by sealant. If the sealant is too high, it might cause interference with the patient's bite. So that's why it's important that you check with the articulating paper with the holder. And of course, that's the last step. You want to make sure that the bite is not high before they leave. Floss. You want to make sure that you're flossing to make sure that there's that you didn't put the sealant in the interproximal, that you didn't block the contacts. So if you put too much sealant, sometimes it flows into the contact area, so you have to make sure you floss. Failures. Now, if you didn't do something right, or there was saliva contamination, it will cause a sealant failure, and basically they'll lose that sealant within the first 3 to 6 months. Sealants can actually last a very long time if the patient is doing their job and if you did a really good job on sealants. Now, another way to take out any sealant that went in the interproximal area, there's something called a mylar matrix strip or metal matrix band that you can put in the interproximal space to remove the sealant. You could also use a scaler and Explorer. Floss is usually the best. I mean, when you place the sealant on, you're supposed to check it before you cure it, because once it's hard, it is very hard to remove it from the interproximal or any of the extra places that you might have dropped it by accident. So get it while it's wet, remove it, and then cure it. Fluoride release. Some brands of sealants release fluoride after polymerization. So again, that means setting, harden. The theory is that the fluoride released from the sealant creates a fluoride-rich layer at the base of the seal groove. Clinical studies comparing the effectiveness of these two types of sealants are still underway. Topical fluoride should not be applied to the enamel surface immediately before sealant procedure, but may be applied immediately after sealant application. So if we did a cleaning, we do the cleaning. If you started out with the paste and then you know that the tooth needs sealants, you can go and get pumice and just hit those teeth that you're going to do sealants on. You do your sealant, and then you finish off with your fluoride. So remember, fluoride is always last after a procedure. because fluoride post-ops are nothing to eat, rinse, or drink for 30 minutes. Now, when you place a sealant on, post-ops are nothing hard, sticky, or chewy. They can pull the sealants out. Now, there's also something called microabrasion, which is air abrasion. These units are sometimes used by the dentist before dental sealants are applied to open the fissures, to remove any slight decay, or to prepare the site for placement of a sealant. Etching precautions for patients and dental personnel. So etching contains phosphoric acid. Patients and dental personnel should wear protective eyewear when etchings are being used. You want to avoid contact with oral, soft tissue, eyes, and skin. And in case of accidental contact, flush the exposed area immediately with large amounts of water. So we have an eye wash station. You would use the eye wash station. If it gets on your face, get a gauze. You should have gauze always, and wet it and remove it right away. Sealant precautions. Do not use sealants on patients with known acrylic allergies. To reduce the risk of an allergic response, minimize exposure to these materials. Use protective gloves and a no-touch technique. If skin contacts occurs, wash the exposed skin with soap and water. Acrylates may penetrate gloves, and if sealants touch gloves, remove and discard glove. Wash hands immediately and remove glove and re-glove. Now, anytime you get anything on your gloves, you should have gauze again nearby you so you can kind of wipe it off on the gauze. Don't keep stuff all over your hands because you do transfer it to their face or yours. If accidental eye contact or prolonged contact with oral soft tissue should occur, again, flush with large amounts of water. Protective glasses should be used by operators when using light cured resins. Protective eyewear should also be provided for the patient during sealant procedures. So general tips on sealant materials: always replace caps on syringes and bottles immediately after use. Do not expose the materials to air or light. Do not store the materials in proximity to eugenol containing products. Most etchants and sealant materials are designed to be used at room temperature. Check the manufacturer's recommendation, and the shelf life of most sealant products at room temperature range anywhere from 18 to 36 months. Some people even place sealants in small refrigerators. You might see a small refrigerator in the dental office if there's products in there, because there are several products that should be stored in refrigerator, including x-rays, believe it or not. Do not store food in there. If you see a refrigerator in the office, don't be putting your food in there, because that's a big no-no. You don't put food and products in the same refrigerator, so be careful about that. Important information: always read and carefully follow the manufacturer's instructions when applying dental sealants. Application technique and etching times vary between manufacturers. For example, some manufacturers discourage the use of polishing paste that contain fluoride, and other manufacturers do not consider fluoride polishing paste to be contraindicated. So again, every brand is a little bit different. Most of the brands I've used does need pumice and no fluoride. Otherwise, the sealant won't stick. Factors in sealant retention: moisture contamination is the primary cause of failure of sealant retention. So if you didn't dry the tooth well, if you didn't isolate the tooth well, you should be using saliva ejector, cotton rolls, dry angles. Inadequate etching is also a factor in loss of sealant retention. So I mentioned to you already, if the sealant, the etch is supposed to be on for 15, 30 seconds, 60 seconds, whatever it is, you need to leave it on there for that amount of time. Dental sealants should be examined at each recall visit to be certain that the sealant material has not been partially or totally lost. And again, if it's a well done sealant and you have a great patient, they usually last anywhere from 5 to 10 years, which is really good. My kids, they got sealants in their teens, and they're in their mid-20s, early 30s, and they have still their sealants on their teeth and no cavities, which is great. They're very lucky. All right. Any questions?